Hello, my name is Dustin Anderson. I'm here talking about my reflections on my spinal evaluation process for evidence-based holistic healthcare 2. Um, so overall, I would rate myself as an intermediate, if that makes any sense. I'm not a beginner or novice by any means, and I'm not an advanced or an expert by any means. I feel like I'm in that middle ground of I sort of know what I'm looking for, and I can get down the right road. It may take me a little bit longer than it would someone that you would say is an advanced clinician with spinal evaluations, but I'm not taking as long as I used to, and I'm more confident in my abilities to assess spinal problems, back problems than I was when I first started out. So I'm at that good intermediate range, and I'm comfortable with that because I've been practicing for 4.5 years. So I feel like I'm on track because the spine's pretty confusing. It seems overwhelming at the beginning, but it's not that bad once you just take a step back and look at it a little bit more. Um, what I think some of my strengths are is um, I think that when I take a history and I'm talking to the patient, I always keep the spine in the back of my mind. For instance, if they're coming in and they just got doing a long run or something like that, their hips are tight and they say they're having some burning tingling down the back of their leg. You always want to think about there's some sciatic involvement. Or when I was working football, they come in and say their arms stinging or that they're having trouble gripping. Look at the brachial plexus. Usually, I found with spinal injuries or spinal problems or spine problems, nerve problems, it's not going to be directly over the spine itself. It's going to bleed somewhere else in the body, and you sort of got to trace that road back to the spine. Um, some of my weaknesses, I think, I've been working in the military setting for 2.5 years. So when reading the Canadian C-spine rules, I've been out of that particular atmosphere or setting where acute neck injuries or acute trauma happens. If it's going to happen, in my setting, they're going to fall from an obstacle or fall from a truck or something. It's not so much with the sports part of it now. So I think that's becoming one of my weaker areas is spine boarding and that acute care management of spinal injuries, especially C-spine injuries. And I really didn't think about that till I was reading that article. So that was sort of a good wake up to like, hey, go back, read this, refresh, just in case it happens. Knowing my luck, it'll happen, and I won't be as sharp or as quick as I need to be when that happens. What do I find most useful with my decision making process? It goes back to what I said earlier. Listen to the patient, and if you have to, follow it back to the spine. For example, if they're having numbness, tingling in their fingers, but they're complaining of shoulder pain, and you ask them that, you always have to clear the neck with shoulder. With any type of shoulder pathology, especially if they're having numbness and tingling in their fingers. If it stops at the elbow, more than likely it's just going from the shoulder to the elbow. But if it's from the shoulder to the hand, you definitely got to look at the neck, and it may be a neck issue causing the problems. Another thing that I think I do well now is actually looking at the skin, looking for atrophy or for anything, muscle weakness, along those lines, bilateral, especially if you have muscle weakness with atrophy. You need to think that there's something going on with the nerve. I've not seen it a lot. Usually when I see things like that, it's with long thoracic syndrome, and it's usually with bad scapular winging. And it took me a little bit to be able to pick up on that. When you first start out, everything's a winging scapula, but when you see a couple long thoracic palsies and it really pops out, you know what you're looking for. And what are some areas that I can improve on? Definitely with treatment, I think is the next step. Whether I've worked with some clinicians that were big into McKinsey and things along those lines, or conservative treatment. I've seen both work, and I think that's where I really need to focus my energies. Are moving on with spinal evaluation is on the treatment and rehabilitation. For steps to improve that process, to improve my spinal evaluation process before I come up for the DAT weekend and before next semester, I think I'm going to see if Carrie will take me on as a mentee. She's certified in McKinsey. I think she's, what did she say, a diplomat in McKinsey. I think that's a little bit higher than certified in McKinsey. So I can get that point of view and learn from her with that way, and continue to read, reread, and continue to look at the research and push forward, and continue to have controlled failures with evaluations. I mean, that's the only way we're going to learn, and hopefully I won't hurt anybody along the way. I don't think I will. No, I won't with that one, but just not knowing, just answering those questions that I don't know when they pop up has helped me out the most when I've been a clinician. So when someone walks in and I don't know the answer, that's when I start to learn quite a bit. And I think that's why I've grown with the spine over the last 4 years, is because I've had a lot of people walk in, I've not known, and I've had to go find that answer. So again, just with improvements, work with Carrie, and continue to keep doing what I'm doing.